similar medicine. Now some quotations are there which is very much important. In exam they will ask quotation and say who wrote this. First quotation is very unique. May the devil take all the repertories. Dr. AZD. Dr. AZD was renowned physician. You can also know about him from the Organon. He was the person who suggested Hahnemann to prescribe two medicine at a time in homeopathy. Two homeopathic medicine at a time to the person. And for a moment, Hahnemann was also convinced. But after some experiment, Hahnemann discarded his concept. It is written in the appendix of the Organon. He was very close to the Hahnemann. But when the concept of repertory came, he was totally against it. That's why on those days he said, may the devil take all the repertories. But in later days he understood the use of repertory and in later time he followed. Dr. Kent. He must then study the repertory until he learns how to use it so that he can find what he wants when he needs it. So, for using a repertory, understanding the repertory is very much important. Means you have to go through page by page. What are the rubrics are there in this whole repertory? Until and unless you will understand all the rubrics, you will understand the meaning of the rubric. How you can find when patient will come to you? How we will think that this symptom is present in this repertory? So that's why Dr. Kent said, read each pages. Once I asked actually, in Kolkata, very less people use repertory. I have studied in NIS. I am studying since last 10 years. We rarely use repertory. We only see when in doubt. And first thing is there, when in doubt, then use repertory. But what is the habit of other people I have seen? Patient came, repertory started. कंप्यूटर पे बटन दबना शुरू हो गया. ऐसे रेपर्टरी नहीं होता है. We should not use repertory as a mechanical use. Artistic use is necessary. And for artistic use, understanding is necessary when to see repertory and when to not. The proper use of repertory will lead to correct offhand prescribing in simple cases in from 10 to 20 years. It will take 10-20 years to learn repertory. The mechanical use of repertory never leads to artistic prescribing nor to remarkable result. Dr. Kent. The use of it is the best repertory. Now, Dr. Emil Dhaule. A tool is as good as the workman who handle it. A bad workman naturally blames his tool when things start going wrong. So, the productivity of a tool, a machine, it depends who handle it. So, Emil Dhaule was great homeopath. He was from Maharashtra. Maharashtra people will knows more about him than me. He was the son of Dr. L.D. Dhaule, who was great homeopath and great allopath also. And M.L. Dhaule Institute is also there in Palghar, Maharashtra, where PG courses happens. A repertory is guide that no one can practice homeopathy without its age. Diwan Harishchand. Diwan Harishchand was one of the great homeopath of his time. He was also the physician of President of India, as well as he was one of the richest homeopath of all time. He was from Delhi, and once upon a time only few Rolls-Royce car was there in India, and one Rolls-Royce car was owned by Dr. Diwan Harishchand. You have studied about Kent's repertory. One of the Kent repertory edition, that is known as Final General Repertory, is published in India in 1974. That repertory was written by mane compiled by Diwan Harishchand and Pierre Schmidt. We will study later. No consensus homeopathic doctor can practice homeopathy in a serious and scientific way without a repertory. See, both Diwan Harishchand and Pierre Schmidt both are giving same line of suggestion. Diwan Harishchand said a repertory is guide that no one can practice homeopathy without its aid. Pierre Schmidt said that no consensus homeopathic doctor can practice homeopathy in a serious and scientific way without a repertory. One important line is written by the Pierre Schmidt, also asked in the exam. The more the allopath grows old, the more he is pessimistic. The more the homeopath grows old, the more he is enthusiastic and optimistic. Now, one of the thing I am going to tell, which you will find in no book, no guidebook it is written. It was, I have taken it directly from Master Hahnemann's book of chronic disease. When I read chronic disease, I got this line related to repertory, so I am sharing. Actually, you all know Master Hahnemann started the thinking of repertory from fragmenta. I will talk something in the last of this session, repertory. So, his view was to make one index, one repertory like thing, which can be used in emergency, so that in short time we can get the desired drug and desired result. In chronic disease, what he is saying about repertory, just see. For this purpose means selecting a medicine for Sora. He is telling in the chapter of Sora. For this purpose, physician should not be satisfied with any of the existing repertories. Physician should not be satisfied with repertories. A carelessness only too frequent, which many people do, and now also many people do. Put symptom in the mobile app and computer and give the medicine. For these books are only intended to give light hints as to one or another remedy. What Hahnemann said? That repertory gives only light hints that might be selected, but they can never dispense him from making the research at the first fountainhead. Now, what is first fountainhead? First fountainhead means materia medica. Even you are taking suggestion from repertory, you go to the first fountainhead, that is materia medica, then only prescribe the drug. Now, next what he said. He who does not take the trouble of treading this path in all critical and complicated diseases, and indeed with all patience and intelligence, but contents himself with the vague hints of the repertories in the choice of a remedy. You are not searching materia medica, you are not studying patient hard, you are not studying materia medica hard, and you are only searching repertory and putting the medicine, and who thus quickly dispatches one patient after the other, seeing one patient and quickly after another patient, does not deserve the honorable title of genuine homeopath. Those homeopaths does not deserve the honorable title of genuine homeopath, but is rather to be called a bungler, who on that account has continually to change his remedies until the patient loses patience, and as his ailments have of course only been aggravated, we must leave this aggravation of diseases, whereby the art itself suffer discredit instead of unworthy disciple of art. And patient will not be cured, and what will happen? You will keep changing medicine, you will take the hint of repertory without searching materia medica, you will prescribe one medicine not working, another medicine, and after that the art will be discredited, the homeopathy, and only because of these kind of disciples, wrong disciples, because they are not genuine homeopath, they are bunglers. Master Hahnemann in the book The Chronic Diseases, the chapter of Sora. It may happen that more than one medicines are also there in all the cards. All the cards mean all the selected cards. So you have to compare with Materia Medica. In card repertory, I will discuss more detail in later classes. Examples: Boger card repertory, Field card repertory, Sankarshan card repertory, Kishore card repertory. Just see the picture of card repertory. Just see this picture. Here symptom number is written 12, and I think it is of urine chapter, ammoniacal order of urine. See, name of medicines are printed. See, ABRO, abrotenum, AMB, Embra, ARAM, Aram, ARAN, Arania, ASC, Esculus, Bellis, Cactus, Camphora, like that medicines are there. And just see, here you are seeing the black, it is punched. So benzoic acid, ammon, carb, aurum, these drugs, canthris, are covering this symptom. And what is the symptom? Ammoniacal urine, ammoniacal order of urine. So these are punched. So this is one card. Now see one more type of card. This is Jugal Kishore card. Kishore card. Here symptom number, rubric number and symptom is written. And here you will see name of the drugs are not there. Numbers are punched. So if you will read in detail, you will understand that how you will read these numbers. Here holes are there. So each hole describes some number, and that number is having some drug which is written in one small book. Will contract. So just think of this. Suppose this is your body. This is upper limb. Here blood vessels came, and here sympathetic constriction. When sympathetic is acting, it is normal. The blood vessel will be of normal size, constricted. Less blood will be there in this peripheral circulation. But if loss of sympathetic control, then what will happen? This vessel will dilate and more blood will come to periphery. Then what will happen? In central area, blood will be less, and in periphery, blood will be more. So what will happen? If central area blood will be less blood will be supplied to the brain, heart, lungs, kidneys, and less blood supplied to these organs will create problem. So this is known as vasogenic shock. Neurogenic, caused by spinal cord injury or spinal anesthesia. Vasogenic shock happens due to many causes. Neurogenic, if you will get spinal cord injury, your sympathetic nervous control will be lost. Psychogenic, सडनली आपको दुख हो गया, कोई के साथ ब्रेकअप हो गया, डाइवोर्स हो गया, फ्राइट हो गया, आप इतना शॉक में चले गए, टेंशन में चले गए कि आपका ब्रेन काम नहीं कर रहा है, आपका ऑटोनॉमिक नर्वस सिस्टम काम करना बंद कर दिया, इसलिए इतना टेंशन में नहीं जाना चाहिए, और वहाँ पे सिंपैथेटिक नर्वस कंट्रोल लॉस हो गया, उसके चलते सारा ब्लड पेरिफेरी में आ गया. साइकोजेनिक. एनाफाइलेक्टिक, मैसिव पेरिफेरल vasodilation caused by release of histamine and slow release of anaphylactic substance. Many people are very prone to allergic condition. They exposed to some type of pollen, allergens, etc. And after that, they produces large amount of histamine and allergic reaction, which led to peripheral vasodilation. is known as anaphylactic. Hypovolemic shock mechanism. What happens when blood volume decreases in the body? Decreased circulating blood volume. Blood volume in body decreased. Stimulation of sympathetic nervous system leads to peripheral, यहाँ पे vasoconstriction, vasoconstriction. जब सिंपैथेटिक अच्छा काम करेगा तो कॉन्स्ट्रिक्शन होगा, जब लॉस होगा तब डायलेटेशन होगा. तो जब हमारे ब्लड में ब्लड वॉल्यूम कम हो जाता है, हमारा पेरीफेरी कॉन्स्ट्रिक्ट हो जाता है, ताकि पेरीफेरी को ज़्यादा ब्लड ना मिले, कम ब्लड मिले, ताकि सेंटर में ब्लड ज़्यादा हो और हमारे हार्ट को, लंग को, ब्रेन को ब्लड मिलते रहे. तो पेरीफेरल वैसोकॉन्स्ट्रिक्शन. स्टिमुलेशन ऑफ एड्रिनल मेडुला. एड्रिनल मेडुला से एड्रिनलिन एंड नॉर एड्रिनलिन निकलता है. इसको कैथेकोलामाइंस भी बोलते हैं. ये एड्रिनलिन नॉर एड्रिनलिन क्या करता है कि ये एड्रिनल मेडुला से निकलता है और जो सर्कुलेशन है उसको ठीक करता है. कॉन्स्ट्रिक्शन ऑफ आर्टेरियोल्स इन स्किन, सबक्यूटेनियस फैट, स्केलेटल मसल. आर्टेरियोल ऑफ स्प्लैंक्निक ऑर्गन. स्प्लैंक्निक ऑर्गन्स क्या होते हैं? जो बड़े बड़े ऑर्गन हमारे पेट में रहते हैं, स्प्लीन, लीवर एटसेट्रा. वहाँ पे क्या होगा कि कॉन्स्ट्रिक्शन होगा ब्लड वेसल का, ताकि वहाँ पे ब्लड कम जाए और सारा ब्लड किधर जाए. ब्लड वॉल्यूम कम है ना, तो ज़्यादा इंपॉर्टेंट ऑर्गन के तरफ ब्लड को ले जाना पड़ेगा. तो पेरीफेरी का जो ऑर्गन है, स्किन है, पेरीफेरी अपर लिम, लोअर लिम है, ये सब जगह कॉन्स्ट्रिक्शन होगा और सारा ब्लड कहाँ जाएगा? सेंटर में, हार्ट, ब्लड और लंग के तरफ. फाइनली आर्टेरियोल्स ऑफ किडनी, देयरबाय मेंटेनिंग ब्लड फ्लो टू द हार्ट एंड ब्रेन. और फिर क्या होगा कि कम ब्लड वॉल्यूम में भी हार्ट और ब्रेन काम करते रहे. एंजियोटेंसिन एंड वासोप्रेसिन कॉजेस वाटर कंजर्वेशन एट किडनी. जब भी बीपी लो होता है तो क्या होता है? जब भी पानी ज़्यादा रोकना होता है बॉडी में, किडनी से नहीं निकालना होता है, तो एंजियोटेंसिन और वासोप्रेसिन किडनी पे एक्ट करता है और डिस्टल ट्यूब्यूल पे वाटर को कंजर्व करता है ताकि और लॉस ना हो. तो ये सारा मैकेनिज्म एक्टिव हो जाता है जब भी हमारे बॉडी में ब्लड कम होता है. क्लिनिकल फीचर. अब क्या क्लिनिकल फीचर होगा? ऐसा ऐसा प्रॉब्लम हो गया. एट फर्स्ट ऑफ स्किन, पहले स्किन का फीचर आएगा, फिर किडनी और फिर अदर विसरा और लास्ट में हार्ट और ब्रेन. अगर वो शॉक और बढ़ते गया, आप उसको फ्लूइड नहीं दिए, उसको ब्लड नहीं दिए, और बढ़ते गया और बढ़ते गया, लास्ट में पेशेंट मर जाएगा. माइल्ड शॉक, लेस देन 20% ऑफ ब्लड वॉल्यूम डिप्लीशन. मान लीजिए आपके ब्लड 5 लीटर है, 20% से कम लॉस हुआ है, मतलब अभी भी 4 लीटर से ज़्यादा ब्लड है आपके पास. तो एक्सट्रीमिटीज स्पेशली द फीट्स आर कोल्ड, पेल, मे बी मॉइस्ट. एक्सट्रीमिटीज वगैरह में ब्लड कम जाएगा तो वहाँ पे कोल्ड कोल्ड आपको दिखेगा सब. नाउ पोटेशियम इज वेरी मच इम्पॉर्टेंट. एक्चुअली इट इज पोटेशियम helps in our muscular movement also, and in cardiac muscles potassium is very necessary. So ECG changes is very much important in potassium problem. You actually, we homeopath, we do not have the experience of treating patient in emergency. If you will go to any emergency ward of allopathic hospital, what you will see? You will see most of the patients are bedridden. They are not having the power to walk, talk. They are bedridden. Why this condition happens? These conditions happen in electrolyte imbalance state. And if potassium is low or high, it is dangerous for the person, also to the heart. That's why it is monitored very closely along with ECG changes. So sometime in exam it has asked ECG changes of hypokalemia, means low potassium, and ECG changes of hyperkalemia, high potassium. So what is the ECG changes of hypokalemia? A small or inverted T wave. Suppose this is P wave, this is QRS and this is ST. So this is the T. T is above. Now in hypokalemia you will see T is down. Depression of ST segment. This is ST, this is S and T. This is T, this is ST segment. ST segment will be depressed. This will not be like this will be little bit depressed. Prolonged QT interval. This is Q and this is T. This interval, this is Q, this is T. This interval will be prolonged. Prominent U wave. After PQRST, the U wave will be prominent. After T, when U wave comes, this will become prominent. U wave prominent, inverted T, ST segment depression. These all are feature of hypokalemia. ECG changes of hyperkalemia. Tall T wave. The T will be tall. Sometimes it will exceed this R. Let's study few minutes materia medica. Full name of Allen's keynote is Keynotes and Characteristics with Comparison of some of the leading remedies of the materia medica with bowel nosodes by Henry Clay Allen. It was published in 1898. In last PG exam 2024, they asked one question: how many of editions were published by Allen and how many editions were published later? 2 editions were published by Dr. Allen and later editions were published by publishers and different people.